Welcome back to the deep dive. Today we're jumping into a really key topic, especially if you're prepping for your MSRA. We're talking about keratitis.
That's right.
Consider this your sort of express lane to getting the essentials down for this eye condition.
We've got those focus revision notes handy.
Yep. And our goal really is to unpack the core stuff about keratitis, what it is, the causes, how you spot it, what you do about it, make it stick for those exam questions.
Exactly. Taking those sometimes quite dense notes and making them, well, easier to digest and hopefully more memorable too. We want you to feel confident when it comes up.
Okay, let's dive straight in then. Simplest terms first.
Huh?
What exactly is keratitis?
Right. So basically, keratitis is inflammation of the cornea.
The cornea, that clear front surface of the eye.
Precisely. The bit you see through. And look, while any eye inflammation isn't pleasant, it's really, really important to note that microbial keratitis isn't like, say, conjunctivitis.
Okay, how so?
It's serious, genuinely sight-threatening. It needs immediate attention. So, yeah, not something to brush off.
Sight-threatening. Okay, that definitely lands the urgency. So what kind of things can actually trigger this inflammation?
Well, it can stem from a few different areas. Infections are probably the big one people think of. Various bugs, basically. But it can also come from injuries, trauma to the eye, or underlying autoimmune problems where the body kind of attacks itself. Even just irritants from the environment can set it off.
Okay, causes. Let's break that down a bit more. You mentioned infections. The revision notes probably split things into infectious and non-infectious.
They do, yeah. That's a good way to think about it. So on the infectious side, you've got your usual suspects. Bacteria, for instance.
Like?
Staphylococcus aureus staph is a common one. And Pseudomonas aeruginosa, that one's particularly nasty, especially with contact lenses.
Pseudomonas. Why is that one so bad with contacts?
It's quite aggressive. It can form these biofilms on the lens surface and pumps out toxins that damage the cornea pretty rapidly.
Wow, okay. What else in the infectious category?
Then you have fungi, things like Fusarium, Aspergillus, and parasites. Acanthamoeba keratitis is a really important one.
Acanthamoeba. I've heard that links to water and contacts.
Absolutely. Huge link. Poor lens hygiene, rinsing with tap water, swimming in lenses, all big risks for acanthamoeba. And finally, viruses. Herpes simplex is the main one there.
Okay, quite a list of potential culprits. Now, what about the non-infectious side? Things that irritate the cornea without an actual bug involved.
Right. So environmental factors are pretty significant here. You can get photokeratitis.
Like sunburn for the eye.
Essentially, yeah.
Yeah.
Too much UV light, skiing without goggles, maybe welding without protection, that kind of thing. Then there's exposure keratitis that happens if the eyelids don't close properly, maybe after nerve damage or something, so the cornea dries out.
Makes sense.
And one more related to contacts is Claire, contact lens acute red eye.
Claire, is that an infection?
No, that's the thing. It's usually a sterile inflammation, kind of a reaction, sometimes from overwearing lenses or maybe sensitivity to lens solutions.
Interesting. Okay, contact lenses are definitely a recurring theme here, which leads us straight into risk factors. Who's most likely to get keratitis?
Yeah, contact lens wear is definitely a major one. And it's not just wearing them, it's how you wear them. Poor hygiene is a massive factor.
Like not cleaning them properly.
Exactly. Or using tap water, like we said with Acanthamoeba. Sleeping in lenses that aren't meant for overnight wear. All that ramps up the risk considerably.
Okay, clear link there. What other factors make someone more susceptible?
Well, any kind of eye injury, ocular trauma, that breaks the cornea's natural barrier. Also, people with weakened immune systems, maybe due to illness or certain medications, they're more vulnerable to infections generally, including in the eye.
Right.
Even things like severe dry eye syndrome can be a risk factor. You need a healthy tear film to protect the cornea.
That makes sense. Tears aren't just for crying.
Definitely not. They're protective. And then exposure to contaminated water or soil, again, can introduce bugs. And certain jobs or hobbies with higher eye injury risk, obviously.
Got it. So we know the causes, the risks. What's actually going on inside the cornea when it gets inflamed? The pathophysiology.
So fundamentally, you get inflammatory cells rushing into the cornea. This is the body's defense mechanism trying to deal with whatever the trigger is, infection, injury. But the cornea is such a delicate, precise structure that inflammation itself, even though it's meant to help, can cause damage, clouding, scarring.
And is it different if it's an infection versus something non-infectious?
Yeah, slightly. With infectious keratitis, the pathogens, the bacteria, viruses, whatever, are directly invading and damaging the corneal tissue. In non-infectious types, it's more about the inflammatory response being triggered by other things like the UV and Photokeratitis or the reaction in glare. But inflammation is the common factor.
Okay, that clarifies the how. Now, differential diagnosis. If someone comes in with a red sore eye, how do you figure out it's keratitis and not something else that looks similar?
Crucial point,
Ooh,
because misdiagnosis can lead to the wrong treatment. So you need to consider other possibilities.
like what?
Well, conjunctivitis, obviously. Viral or bacterial. That also causes redness, maybe some discharge. But usually the pain and the light sensitivity, the photophobia, aren't quite as intense as with keratitis. And the vision isn't usually as blurred.
Okay.
Dry eye syndrome can cause redness and discomfort too, but again, usually not that severe acute pain. Then you have things like corneal dystrophies, which are more chronic conditions, a corneal abrasion, a scratch that's painful, but there's usually a clear history of injury.
Right, like getting poked in the eye.
Exactly. And uveitis, which is inflammation deeper inside the eye, can also cause a red, painful eye, but often has other signs affecting the iris or pupil. So you look at the whole picture.
Combination of symptoms and signs is key then. What about how common this is, epidemiology-wise?
It's tricky to get exact figures for all keratitis because the causes are so varied, but overall it's considered relatively common.
Okay.
How often you see, it really depends on the specific cause and the risk factors in that population. You know, more contact lens wearers, potentially more microbial keratitis if hygiene isn't great.
Makes sense, it varies.
Yeah.
So let's say someone does have keratitis. What are the classic things they'll complain about? The clinical presentation?
Okay, key symptoms. Eye pain is usually a big one, often quite severe, maybe a deep ache. Redness, erythema. Photophobia, really sensitive to light, finding it painful. Blurred vision is common, often tearing, watery eyes, and frequently this feeling like there's something in the eye, a foreign body sensation. Oh, and maybe some discharge too.
And what would you actually see on examination? Any specific signs?
Yes. A really key clinical sign is corneal opacity. The normally clear cornea looks hazy or cloudy.
Right, losing its transparency.
Exactly. And in more severe cases, you might even see a hypopyon. That's basically pus collecting in the anterior chamber, the space at the front of the eye behind the cornea. You see sort of fluid level.
Wow, okay. That sounds serious.
It is. So red, painful eye, maybe cloudy cornea, maybe a hypopyon, definitely thinking keratitis. Actually, there's a mnemonic that can help remember symptoms. FORPAD.
FORPAD, what's that stand for?
Foreign body sensation, ocular pain, redness, photophobia, and discharge. FORPAD.
FORPAD. Okay, that's handy. So patient comes in, you suspect keratitis based on FORPAD. What investigations do you do to confirm and figure out the cause?
Number one tool is the slit lamp examination. That's essential.
The big microscope thingy.
Yeah, exactly. Lets you get a really magnified view of the cornea, look for that opacity, infiltrates, maybe the hypopyon. Then, if you suspect an infection, which you often do, corneal cultures are vital.
Taking a sample.
Yep. Gently scraping the cornea to get a sample to send to the lab. That helps identify the specific bacteria or fungus. For viruses or maybe Acanthamoeba, PCR testing can be really useful too.
Okay. Any fancy imaging?
Sometimes. In more complex or difficult cases, you might use OCT optical coherence tomography, which gives detailed cross-section images of the cornea, or corneal confocal microscopy, which can actually visualize cells, and sometimes even the bugs themselves, like Acanthamoeba cysts.
Right, for the tricky ones. So you've done the exam, maybe got culture results back. How do you actually treat keratitis?
It completely depends on the cause. That's the key thing. You treat the underlying problem.
So if it's infectious,
then you need antimicrobials. Targeted ones if possible, based on the cultures. So topical antibiotic drops for bacteria, antivirals for herpes, antifungals for fungal keratitis. Sometimes you might need oral meds too, or even IV in really severe cases.
and non-infectious, like the Photokeratitis or Claire.
There, the focus is usually on reducing the inflammation. So often topical steroid eye drops are used, carefully monitored of course. Lubricating drops are also really important, artificial tears, to support the cornea as it heals. And managing any underlying condition, like treating dry eye or autoimmune disease.
Okay. Now, you stressed the contact lens connection earlier. Anything really critical about managing keratitis in someone who wears contacts?
Yes, absolutely vital. Listen up, this is MSRA gold. A contact lens wearer presenting with a painful red eye must be assumed to have microbial keratitis until proven otherwise.
Assume the worst, basically.
Yes, because the consequences of missing something like Pseudomonas or Acanthamoeba are so severe, so immediate referral to ophthalmology is needed urgently.
And before they get to the specialist, what should happen?
First step, stop wearing the contact lenses.
Uh,
Immediately. Take them out. Don't put them back in.
right.
Often, broad-spectrum topical antibiotics like quinolone are started straight away, even before culture results, just to cover the likely bacteria. And sometimes drops like cyclopentolate are given to ease the pain and inflammation.
So stop lenses, start antibiotics, pain relief, and get them seen ASAP.
You got it. Pain-thing red eye plus contact lens. Urgent ophthalmology referral. Don't forget that.
Definitely memorable. What about the outlook, the prognosis? How well do people recover?
It really varies. Depends heavily on the cause, how bad it was when they first presented, and crucially, how fast they got the right treatment.
So early treatment is key for a good outcome.
Massively. If infectious keratitis isn't treated quickly, the risk of permanent vision loss from scarring is high. But get the diagnosis right, get the right treatment started promptly, and the prognosis is usually much, much better. You can often minimize long-term damage.
Good to know. Early action makes such a difference. What are the potential long-term problems, the complications, if things don't go well?
Well, the big ones relate to corneal damage. Scarring is a major issue. It blocks light, causes blurred vision.
Permanent blurring.
Can be, yes. The cornea can also get thin and weak. That's corneal thinning. And in really bad cases, it can actually perforate.
A hole right through the cornea.
Yes, a corneal perforation, that's an emergency, needs surgical repair, and obviously the ultimate risk is significant permanent vision loss.
Scary stuff. Any other complications?
You can get secondary infections spreading inside the eye, like endophthalmitis, which is very serious. And sometimes, even with treatment, if the damage is too severe, the only option to restore some sight might be a corneal transplant later on.
So it really highlights, again, why getting onto it quickly and correctly is so important.
Absolutely. Timely, appropriate management is everything for preventing these complications and trying to preserve vision.
Okay, so quick recap. Keratitis equals corneal inflammation. Loads of causes, infectious and non-infectious. Diagnosis needs careful examination, maybe cultures. Treatment depends on the cause. And for contact lens wearers with a painful red eye, it's an emergency. Stop lenses, get them seen.
Perfect summary.
And just to help lock that contact lens point in for the MSRA, maybe think, red, painful, no contacts now. Quick reminder of the signs and the immediate action.
Nice one. Simple and effective. And think about how a question might be phrased like, a contact lens wearer presents with a painful red eye and photophobia. What's the most likely initial management step?
And based on what we've said, the answer's got to involve stopping the lens wear and getting that urgent assessment.
Exactly. That urgency is key.
Right. Look, understanding keratitis properly is crucial, not just for exams, but for practice, too. Definitely keep exploring related eye topics. It all links together. And for more great MSRA revision help, do check out passthemsra.com.
And freemsra.com as well. Both excellent resources.
Definitely. Well, thanks for diving deep into keratitis with us today.